Welcome to the presentation for Module 3 for Nursing 150. This is a short presentation that will just cover disorders of the lower GI tract, specifically non-inflammatory intestinal disorders. The first non-inflammatory lower GI disorder that we'll talk about is hemorrhoids. Hemorrhoids are essentially the varicose veins of the GI system. They are unnaturally swollen or distended veins in the anorectal region. They are essentially caused by increased intra-abdominal pressure, which causes elevated portal venous pressure. And just so the prolonged pressure on these veins that are in the lower part of the anorectal region, they become distended because of the increased pressure on them for a prolonged period of time. Different scenarios that can cause a prolonged increased abdominal pressure are pregnancy, constipation with straining, so people who have chronic constipation are chronically straining that area, obesity, heart failure, prolonged sitting or standing, so people who maybe have an occupation where they are sitting for a prolonged period of time, maybe a truck driver or an office worker, can develop, are more at risk for developing hemorrhoids. Sometimes strenuous exercise and weightlifting can also increase their risk factors due to the fact that just the pressure from straining whenever they're lifting can cause hemorrhoids as well. Hemorrhoids are typically a very benign problem unless they become they're just basically very painful and typically can be treated very easily. The patient may develop bleeding from the hemorrhoid swelling, prolapse, which is like a bulging, because they can be external or internal. The most common symptom is the pain that's involved. Other symptoms include itching and mucus discharge. Diagnosis is usually made by inspection and digital examination. Risk factor, basically treatment or interventions are aimed at decreasing the risk factors, so weight loss, diet changes in order to prevent chronic constipation. So that would be increasing fiber in the diet, such as eating more whole grains and raw vegetables and fruits. Encourage patients to drink plenty of water. This also does help to prevent constipation. They should avoid straining when they use the restroom. Some patients may need to undergo a hemorrhoidectomy, which is the surgical removal. And typically these are for patients who have very severe cases of hemorrhoids that are very painful. Basically, post-operatively monitoring for any bleeding, excessive bleeding, pain control, and signs and symptoms of infection. Diverticular disease is the next disease process that we will talk about. Diverticular disease can be considered non-inflammatory or inflammatory. Basically, the diverticula that are pouch-like herniations of the mucosa of the wall, of the intestinal wall, are typically non-inflammatory, but they can become inflammatory. So they're a little bit of both. But the risk is that they will become an inflammatory process, and that's when the patient begins to have trouble. So essentially, their diverticula are just pouch-like herniations along the intestinal wall. These are most commonly found in the colon, so the large intestine. So basically, they're little pouch-likes, and I've got some pictures here in the next few slides that just develop on the wall of the colon, and they can be there and not bother anything. They can occur in any part of the small or large intestine, but usually occur in the sigmoid colon, so that's the lower portion of the colon. The muscle of the colon becomes rigid and develops these little diverticula. Now, they can be just fine. They can never cause any problems. However, there's always the potential of these diverticula to kind of start collecting bacteria in them. So they're kind of like little appendices, almost like a little tiny appendix along the intestinal wall. But they can begin to collect bacteria and undigested food in these little diverticula, and then that's when the infection occurs. So once that builds up, the diverticulum can become a diverticulitis, which is an inflammatory situation that develops within these diverticuli. And these little pouch, much like the appendix, once they get inflamed, can also burst and then result in a very serious illness such as peritonitis. So just to summarize, you can have just diverticula, which are little pouch-like areas along the colon. They can be harmless until they begin to collect bacteria and they become inflamed, and then they become a diverticulitis, and that's when they become a disease process, an inflammatory disease process. And this is just kind of summarizing that as well. Without inflammation, diverticula cause few problems. And then this is when all of this here is when the problems can start. If the undigested food or bacteria become trapped in them, the blood supply to that area is reduced, and then bacteria forms, and it basically forms an abscess which can perforate or burst. And a perforated diverticulum can progress to intra-abdominal perforation. And remember that word, peritonitis, which is a life-threatening situation where the content of that infected diverticula is now released into the peritoneal cavity, and the body, it's reaching other parts of the body, and the patient can get septic very quickly from this. So it typically has to go to emergency surgery to repair this and to clean out the peritoneal wall. So the diverticular disease can be, harmless until this process develops. So the important thing is to identify a patient who might have a diverticuli, and then we can do some lifestyle changes to hopefully prevent this from ever becoming a diverticulitis. This is just a visual picture of those diverticuli. And remember, we said it does occur mostly in the sigmoid colon, which is the lower part of the large intestine or the colon. And these are just little pictures of what those little pouch-like diverticuli can appear as. And again, if there's nothing built up in there, if nothing gets trapped in there, these can be completely benign and harmless. The actual incidence of having diverticuli is unknown, but it does seem to occur more in the aged. So as we get older, men more than women seem to be affected more. African Americans have more diverticular disease than do Caucasians, and we don't know why that happens. A patient that begins to develop a diverticulitis may have abdominal pain that's typically localized in the left lower quadrant. It can be intermittent at first, but then become progressively steady. Of course, if it is progressing to a peritonitis, the patient will appear more sick. They will have nausea and vomiting, higher temperatures, chills, increased heart rate, with fever as well. Look for any signs or symptoms of a GI bleed. Again, that's that vomiting, coughing grounds, or burgundy colored stools or frank bleeding from the rectum. These can occur. Sometimes bleeding is just because of the generalized damage to the bowel that can cause some bleeding to occur. And of course, any kind of GI bleed can be life-threatening if we're not careful in monitoring it well. Patient, of course, if they have developed a peritonitis, will get an elevated white blood cell count. If they're bleeding, their H&H will drop. So just consider all of that in the nursing care of a patient. Diagnosis of diverticulitis could include x-rays, just that KUB, that kidneys, ureters, and bladder x-ray. Also will show the lower abdominal wall, which is also known as an abdominal x-ray. CT scan may need to be performed in order to get a more definitive diagnosis. ultrasound could, an abdominal ultrasound is non-invasive, and it could help us to support the diagnosis of diverticulitis. Pain management is top priority, and getting the antibiotics on board to control the infection and the inflammatory process is important. Metronidazole, or metronidazole, or also known as Flagyl, is a medication that is very commonly used for, it's a broad spectrum antimicrobial medication that is used often for GI infections, and we talked about that a little bit in Module 2. There's a good chart in your book about diverticulitis, the care of the patient with diverticulitis. Make sure you kind of look through that table. It's a good key elements of taking care of a patient with diverticulitis. Surgical management may need to occur if the bowel is damaged from the diverticulitis and from the infection. A portion of the patient's colon may need to be removed and maybe reconnected, or they might have to, this is in very severe cases, they might need to get a temporary colonoscopy, or not a colonoscopy, a colostomy, which would mean a colon resection, which means removing a piece of the colon and then bringing the colon out of the abdominal wall, which would divert elimination for a while until the colon is able to heal from the infection. Sometimes it's permanent, sometimes it's temporary until the colon can heal. So again, make sure you review the care of a patient with an ostomy, especially a new ostomy. There is a presentation from the wound care nurse here at the Christ Hospital that is posted for you. I highly encourage you to review that interactive presentation to become familiar with the care of patients with ostomies. Okay, this slide begins to discuss intestinal obstruction. Intestinal obstruction is just that. That means that there is something that is obstructing the flow through the intestinal tract. And remember, we talked about the GI tract is meant to be a flow through, and basically what we take in our mouth moves down through the GI tract, and we keep what we need, and eventually what we do not need will be eliminated throughout the anus. So if there is anything obstructing that flow from the mouth to the anus, then the patient can develop problems. Because wherever that obstruction is, it won't let the food go through. And so anything above that obstruction is not going to get moved through, and it will not get absorbed appropriately. So it's important to kind of identify what this looks like in a patient. Some of the reasons are listed here on the slide. Sometimes it's adhesions or scar tissue, tumors, fecal impactions, different, and we have some pictures of this intussusception in the next slide here, which are called, those are mechanical obstructions. Non-mechanical is just an ileus, where peristalsis, peristalsis is what moves the food forward through the GI tract. If there's a problem with peristalsis, that can cause an obstruction as well. The slowing or the movement or a backup of intestinal content. A paralytic ileus is commonly associated with like use of opioids or other drugs that cause a profound constipation, which can also, the reason it causes constipation is it's this almost the sedation of peristalsis. It's the slowing of peristalsis. So any kind of med, surgery, things like that might just slow peristalsis can cause an ileus. Here are some pictures of those different types of obstructions. This is that intussusception, which means it kind of folds over on itself here, which can causing that narrowed tract there. This is where it completely twists. The volvulus type of intestinal obstruction. So just the pictures of lots of different ways this obstruction can occur, but can you imagine how this one might be a little bit trickier than that one to take care of? In order to diagnose a patient with obstruction, the signs and symptoms will appear kind of in the tract that it appears in. There's a good table in your book. It's chart 56-5, are the key features of the small bowel and large bowel obstructions. Basically, with a small bowel, the abdominal discomfort or pain is upper or epigastric distension, nausea, and early profuse vomiting. Because if you think about it, if it's higher up in the small intestine, everything above the small intestine is going to get backed up, and so you're going to see a lot more vomiting there. And with a large bowel obstruction, they'll get more of a lower abdominal distension, intermittent lower abdominal cramping. They typically don't have as much vomiting, and don't get as many fluid and electrolyte imbalances because the food is getting through the small intestine and we're absorbing a lot before it gets to the obstruction. Both of these are very serious illnesses, and they need to be identified early and treated appropriately because they can lead to life-threatening situations. Another chart in your book, chart 56-6, best practice for patient safety and quality of care, nursing care of patients who have an intestinal obstruction, are all things that you will need to read over and know. These are all in your IGGY book. Talks about maybe placement of NG tubes, monitoring the drainage of that NG tube, checking placement, the care of all that stuff. The patient is typically kept NPO until we can identify the problem and do some interventions, because we don't want to keep putting something in the GI system when it's not going to be able to get through and get absorbed. And I really can't stress enough the fact that you need to be aware of how to take care of a patient with an NG tube, monitoring what's coming out, making sure it's patent, things like that. One thing I do want to mention, I don't really have a slide for it in this presentation, but the patient who has malabsorption problems. So basically, for whatever reason, they are unable to absorb the nutrients that they need in the GI tract. If you review the GI tract, that's one of the major purposes of it, is for us to be able to, as we take in food, we are able to absorb the nutrients that our body needs to maintain homeostasis. A malabsorption situation is sometimes patients have a variety of reasons. They have a malabsorption problem. Sometimes it's secondary to surgical procedures. Sometimes it's just a deficiency that they're born with. If patients are unable to absorb their nutrients, they sometimes will need a TPN, or total parenteral nutrition, which essentially means that we will give them nutrition, fluid and electrolytes through their veins. We have to infuse that through a central line, which is a larger line that goes right into their larger venous system, like their on their chest wall. So it's important we infuse it through either a PICC line, which is a peripherally inserted central catheter, or a central line in their chest wall. It's important to know that we need to maintain that infusion if the doctor orders it. And sometimes there's insulin and dextrose in those infusions, so you cannot let that run dry. The patient may develop a hypoglycemia. In the event that it does run dry, you run out of your TPN, and you don't have a fresh bag to hang, you need to hang a bag of dextrose to infuse at, typically they just want you to infuse it at about 10 milliliters an hour. So that's D5W is what you'll be infusing. And this is typically on the orders for TPN. you would infuse this until your bag comes up, and this is to prevent any instance of a hypoglycemia that may occur. We'll talk about this a little bit more in class, but it is important for you all to know that some of these patients, if they have a malabsorption issue secondary to a bowel obstruction, a peritonitis, maybe they have Crohn's disease and they've had to remove a large part of their bowel, and so they're not absorbing things well, we may have to, one of our interventions may be administering total parenteral nutrition. So we need to know how to maintain this and monitor. This concludes part 2 presentation for our nursing module 3 of the lower GI system. The next slide here is just a question just to help you to assess your learning, and you can check your answer in the non-voice presentation that goes along with this one. I look forward to discussing these topics with you more in class.